we're going to speak very briefly about DBT in an intensive setting, a focus on the IOP, the Intensive Outpatient Program in Reinstein. It's been a pretty wild journey until now, with lots of, it's a very dynamic process. I mean, therapy in general is dynamic. Can I say that here? Am I allowed to say? Okay. And nowhere more so is that true than in an intensive setting, which is intense certainly for the clients and just as intense for the clinicians. I had the privilege of stepping in for Sarah for a period of time when she was on maternity leave and really got a very good taste for myself. However, really, Dr. Tzachi Fried, who effectively gave birth to the program, and Sarah, who's been managing it for the past few months, really are the experts in terms of what's going on. So we're going to do a brief case presentation and then sort of drill down on a few of the points that have come up throughout. Okay, should we, let's do it.
So this is a brief case presentation. I changed any pertinent details in terms of the identity of the participant. 28-year-old religious female, single, grew up in an Anglo community in Israel. She was diagnosed previously with ADHD, anxiety, and depression. She was referred to the IOP for a higher level of care following a recent suicide attempt, by which she cut herself superficially, and she herself classified it as a suicide attempt. She reported on intake that she struggled with suicidal thoughts several times per week. She was tried on multiple different medications, one of which she said made her more suicidal. She was in weekly therapy for over 7 years with reported progress, and she had never done DBT treatment before. So her goals for treatment in the IOP, and this is something, on intake, I do a standard psychiatric intake, and then I also ask a couple of things. One is goals. What do they want to get out of this IOP? So for her, she said that she wants to stop her suicidal thoughts, and she also wants to target underlying intrusive thoughts and cognitive loops, specifically about religion. I also asked, just as an aside, for people to be able to commit to not acting on their suicidal thoughts for the duration of the IOP, and to be able to commit to attend as well.
No. Okay, so I'm going to ask a couple of questions, just looking at this case presentation for you, Sarah. This is a person who had been in therapy for 7 years and was actually making reported progress. Can you give us a little bit of a background about why she was referred to the IOP? Superficial cutting, non-suicidal self-injury, something which is pretty common, and we see a lot of, and many clinicians who work with people on the complex post-trauma, the borderline spectrum. This is almost par for the course to see this type of behaviour. Why the referral to a higher level of care, especially in light of the fact that she'd never actually done DBT before? Why not start with regular outpatient DBT?
So the referral was made actually by the treating psychiatrist, as well as the therapist. And it was mainly related to the suicide attempt, the fact that she classified her superficial cutting as an attempt. It signified that it was a step up in terms of her risk level, even if, actually, I guess some would classify it more as a suicidal gesture. It was really the fact that she was attempting. That was number one. Number two is also, she was in treatment for over 7 years. That's a long period of time. And granted, she had never done DBT, but she was in good quality therapy. And the combination of the whole clinical picture, combined with also the fact she was tried on multiple different medications, the outside referring team really felt that she needed that higher level, more intensive treatment at that point.
We've got the clinicians on board in terms of making that referral. What about the client herself? We often find in terms of motivation, being on board with the treatment is tricky, even in an outpatient setting. Can you talk a little bit in terms of some of the challenges that we find in the IOP and in terms of having clients who are motivated, how that plays out?
Okay, so first of all, barring extensive or extreme circumstances, our IOP is in Renana, and I asked everyone to come in person for an intake, just to see, first of all, it shows motivation, and also just to get a sense that they actually can make the trip, because especially coming from, let's say, the Jerusalem or Beit Shemesh area, it is a pretty big trip. The patient herself, or the participant rather, flip-flopped a lot, actually. She came, I even got the sense, actually, during the intake when she said that she wants her suicidal thoughts to stop, she was kind of saying the right answer. Here she was speaking to a psychiatrist who runs a program that is designed to, target suicidal thoughts. She sent me a bunch of emails back and forth in terms of, I'm not sure, maybe. And in the end, she committed. It often is a journey. It's not usually something that, in the intake someone is ready to jump in. It's usually, we ask people to take some time to really think about it, that they're motivated enough, and also logistically that they could arrange it as well, both in terms of the travel, and also it's a twice-a-week program that they can actually do it.
One of the other challenges that jumps out to me is we're talking about someone who had been working for 7 years, and a good chunk of that time was with the referring therapist. How do you manage that transition if you're talking about someone who's got an established therapeutic alliance and is now coming into an intense setting? Do they continue as well, like with the referring clinician? If they're stopping for that period of time, how does that work? How does transition back work? It seems a lot of challenges in terms of changing clinical teams. How does that work, and how is it catered for within the IOP treatment?
This is a hot topic. We ask participants to stop their treatment with their outside clinicians over the course of the IOP. This is something we often get a lot of pushback from participants, as well as referring clinicians as well. A lot of questions like why, we're doing more trauma work, why can't it be parallel? To the point where we actually trialed it for a little bit, actually, to see if it can work, and it did not. One of the reasons that we ask and we insist and we do not budge here is that it's a very fertile, ripe ground for splitting. I think especially with this population, it's not surprising, but in terms of good clinicians, bad clinicians, referring clinicians, that's number one. Number two is a participant herself actually mentioned that, why should I invest in this temporary relationship with this individual therapist over the course of the IOP when I'm just going to go back to my long, well-established therapist? This doesn't really make much sense. And in terms of just investment in the program, we felt that it took away, actually. But it's definitely a struggle. It's something I'm upfront with people about during their intake. I also do speak to the referring clinician. There's often, feelings of abandonment also as well. Why is the clinician sending me to this program, especially if they don't necessarily want to go? And again, it brings up a whole host of other issues. And then before or towards the end of the program, I do reach out to the referring clinician to give what we call in medicine a hands-off. This is what happened, this is what we saw, to hopefully bridge, it's a relatively short program, to hopefully bridge the work that they did in the IOP so that the therapist can continue that work and hopefully make it more effective down the road.
I want to follow up just in terms of, A, what is the role for the individual therapy in the IOP, given that it is so short term? And B, can you talk a little bit about the role of the group work that's done within the IOP as well, and how that balances together? And then I'm going to ask you after about psychiatric follow-up, but we'll get to that.
To talk about. Okay, so just to go over a little bit about the structure of the IOP, and as Shmuel mentions, it's been a challenge. It's also a very dynamic process as well, which we're constantly changing, tweaking things, sometimes bigger things, sometimes smaller things. It's a group-based treatment, so it's group therapy. It's pretty much all group therapy with the exception of 1 hour a week of individual therapy. And it's tricky. Sometimes I'll tell the therapist, like, don't fall into the trap of, going down the trauma route during that 1 hour, because there's so much to talk about and so much to address. But rather, that 1 hour of individual therapy should be to reinforce the work in the group. Okay, what is not being brought up in group that should be brought up in group? Why is it not being brought up in group? And how do we make that happen as well?
Okay, so deep trauma work is not the goal of the IOP. What is it that you want the clients to come out with after what is currently an 12-week program? Yeah, that's number one. And okay, so let's start with that.
Okay, what do I want a client to come out of the IOP? There's no cure, okay? And that's something I also emphasize to people. Many times participants come to our program and think, again, my suicidal thoughts will stop, it'll be cured. The idea is to hopefully alleviate things, to hopefully build insight, and also to give people skills so that they could help manage their emotions in a much more effective way. So for instance, it is not a trauma IOP, and I'm also very upfront with that, but hopefully if someone does have a history of trauma, and I would say the vast majority of our participants do, they'll be able to go on and do that work after they have those skills in place. Being able to, again, target and understand why they're having these suicidal thoughts, why they're having this not suicidal self-injury, eating disorders as well. Kind of, again, create a sense of stability, and we'll talk in a minute about like my role as a psychiatrist using medications so that they could go on and continue to do effective work as an outpatient.
Yeah, skills are something that are offered even within regular outpatient DBT, and they're goals that we find even just within a regular outpatient group. Why the IOP? Like, what is it? Is it just a quantitative difference? Is there a qualitative difference necessarily to what's done within the IOP?
I do believe it's actually both quantitative and qualitative. Quantitatively, it's a 10-hour week program, which is obviously much more than a 1 hour, twice, 2 hours a week individual therapy. But it's also a qualitative difference. And the reason for that is it's a team-based approach. And it's an integrative team-based approach. So it's myself as well as 4 seasoned clinicians, therapists, all really taking, like, I would call it like a 360 sort of look at a participant. What's going on? We have multiple team meetings a week as well to really understand how someone's, let's say, presenting in group. What's going on in individual? And I think the difference is really the team, the intensity, and this whole, it's a matefet, if I could use that Hebrew word, that is just very different from outpatient. And the hope is, again, to provide more effective care for people who are really stuck, and clinicians as well who are really stuck in this therapeutic relationship.
You mentioned skills, which we're all very familiar with, and one of the cute quotes that you told me once from LIJ was skills and not pills, which is difficult for psychiatrists to come to terms with. Having said that, we're probably a bit of a weird breed of psychiatrists that's happy to work very closely with therapists and within a therapeutic team. Can you talk a little bit about the role of the psychiatrist in an IOP and the work that you do, both vis-a-vis the client and obviously within the treating team as well?
Sure. So, yes, I wish I remember who told me that quote, because I would like to give them credit, but I think about it a lot also. Yes, as a psychiatrist, so I am both the psychiatrist and the director of the IOP. I actually maintain a somewhat removed position clinically in the IOP, meaning I come in briefly in the morning for a check-in and mindfulness, and actually step out and let the therapist do the work in the groups as well as individual. I do meet with people once a week, which is also a rare gem, and it's something I enjoy in terms of moving medications quickly. It's something that enables me to be able to do that when I meet with them once a week. but again, I specifically design myself or place myself a bit removed so that I can have some level of objectivity. I think working with this population, sometimes myself included, can get, drawn into the dynamics, and to be able to take a step away, and also to be able to provide support for the therapists, because this is also a population that could be, quite frankly, draining and difficult and challenging to work with, and be able to set myself a bit aside and kind of overview and take a look at the program as a whole and how things are going. As a psychiatrist, yes, I think it's much easier, I guess I'll speak on behalf of both of us, to hand prescriptions. see people for 15 minutes and then call it a day. Practically, I find myself being a much more effective psychiatrist, and this is what really draws me to this work, actually, and what keeps me going is being able to see people in a different way, in a more intensive sort of way, and have so many eyes and ears reporting to me in terms of what they see and how people are acting, and what progress they're making or not making, to the point that sometimes I find myself making minimal medication changes. I find myself taking people off of medications, actually, which is something I really enjoy. I think especially in this population, we often have people being placed on 2, 3, 4, 5. I've even seen much higher, like long laundry lists of medications, which quite frankly can not only be dangerous, but often is not effective. And again, I do prescribe. I want to make it very clear. I do prescribe. I very often prescribe, but it's done in a more thoughtful way because I'm working in this intensive program.
Okay, so I definitely want to second that. I remember when I left the hospital, and considering private practice, having moved from this team-based approach where you're really integrated with therapists and social workers and really a whole team, and the thought of going into private practice and being condemned to a professional life of isolation, just writing prescriptions and seeing people every 3 to 6 months, if I'm lucky, was not really what I signed up for going into psychiatry. And I think definitely not even at the IOP level, just working within a team is a luxury that I don't take for granted. And I think that we're lucky as psychiatrists to be able to be integrated with other professionals as well. So I'm going to thank the team here that allows me to be a part of the team and to get my fix in being connected to a professional group. I just want to end off with a couple of more questions. Can you talk about some of the changes that have happened in the IOP? When we first set this up, I remember Dr. Yitzi Schechter from Monsey coming and speaking to us. And one of the things, he runs Achieve in Monsey, for those who are familiar, a very large organization, do a lot of wonderful work. And they'd set up their IOP about a year or two before. And one of the words that he used is that it's an iterative process. It is constantly changing in between cycles, within the cycle, which really makes it tricky because it's like a moving target all the time in terms of what's going on. Can you talk about some of the changes that have happened, over the past year or so? Maybe even as much as changing to an all-female team, for instance, was a very big move. I know floaters was another issue, and how that's played out.
So I could talk about this for a long, long time. The program started off a 3-day-a-week from 9:30 to 3:30 program, so pretty intensive timing-wise. Over time, it morphed, and at this point, it's a twice-a-week program from 9:30 to 1:30 with an additional hour. So that was the first thing. Again, we made that change both logistically, financially. Also, again, this is another discussion, but it's a very expensive program to run and to be able to make it more in reach of more people. We also, as well, another reason also, which is something I really wanted to do, is have it twice a week to encourage people to live their lives. I think a lot of times people come to our program and put their lives on hold, and Dafka, I want them to continue if they're working, if they're in school, to be able to incorporate that and have treatment part of their lives as opposed to stopping. That was something I wanted to change. We also switched, again, we had multiple different staff members. We switched to an all-female team, specifically actually because most of the participants do have a history of trauma, often sexual trauma, complex trauma, and kind of create that dynamic of, an all-female environment as well. We had something called floaters, which were therapists who are not in the room actually hanging out outside so that if a participant needed extra help or support, they were able to go out. We actually did away with that because what we noticed is that people are kind of just getting free therapy, not financially free therapy, but kind of not doing the therapy in the group room, but actually leaving and trying to talk about how they're feeling outside and to create a sense of real boundaries in terms of, when we have a program, like you can't leave, in a group room. That's just not acceptable. And if you leave, you might not be able to come back either. What else? I would say, again, I could keep going in terms of the changes. I think personally, one of the words that comes to my mind when I think about the IOP is it's a humbling experience. It's something that I'm constantly learning about, and the therapists as well. Often towards the end of a cohort, we actually just finished a cohort right before Yom Kippur. I said, okay, guys, what are we doing right, and what are we not doing right? And constantly changing, taking a look, making changes, and also realizing that changes, even that are maybe small, are mamash mashmiuti, and kind of rolling and saying, okay, we're going to try it and see what happens, and being open to that is something that I think I've continued to develop and as a psychiatrist, and also hopefully develop a even more effective program.
Maybe to finish off, can you share with us what some of the successes were with this particular young woman, and where we weren't as successful, and what it is that we would still hope to achieve?
Sure. Okay, so I'll tell you the end of the story here. Her suicidal thoughts did not stop. And looking back, I probably should have flagged that a bit more in the intake and said that's not something realistic here as well. What did end up happening is that, she continued to talk consistently about her suicidal thoughts, both in group and individual therapy. I tried her on multiple different medications, lots of side effects that kind of just nothing added up. And at some point, and again, this is, I think, where it comes from in terms of the benefit of working in this integrative, intensive team, I was able to say, hey, what is going on here? There's something else going on here that's just not adding up. And we ended up, myself and then also the therapist as well, got to the point that she actually did not want her suicidal thoughts to end. She actually was holding on to them for very complex family reasons. Her identity, who would I be if I didn't have these suicidal thoughts? They've been with me for so very long. And I told her, listen, we're going to stop medication trials here because we have to first agree on goals and make sure that we're on the same page as well. And ultimately, I guess, again, in a concrete way, she left the IOP still having suicidal thoughts. But we were able to be in touch with her referring therapist, who she did return to actually continue working with, and share with her this idea of, I think there's more here. And this is, I think, where the money is in terms of going forward with the treatment with her, is to understand better what the role the suicidal thoughts play, and maybe what can replace them as well. It was a journey, and is it a success? I think we gained a lot more insight about her. I think she gained a lot more insight about herself. I think the therapist as well gained in terms of understanding the participant a bit more. Okay, so just a few takeaways just to wrap up. And again, I just want to emphasize, it's a program I'm incredibly proud about, but it's also a program that has a lot of challenges as well. And it's something that's constantly dynamic, constantly changing. We're making mistakes, we're learning from them, and yet at the same time also really hopefully providing a service for the therapeutic community out there. So a few takeaways. The IOP is, I would say, particularly useful for complex and risky clients. Again, especially ones who don't speak Hebrew. In my experience, I worked in the Tziburi, in the public system for a bit. There's really a big lack in terms of, for sure, a higher level of care. Even in Hebrew, there's long waiting lists, but in English, absolutely. And kind of what to do with these clients. As well, when therapy once or twice a week is just not enough. You don't feel like you're holding them necessarily and not moving forward. Along the same lines, to help the DIA get unstuck. And I would say this is really where group modalities really come in. I'm a big believer in group therapy. During my training, I trained at Montefiore in the Bronx. We used to do group therapy and forensic units, actually, and the gems that came out of those groups were amazing. Also on inpatient units, I used to run an inpatient unit, group, and I think that also really can help people sometimes get unstuck in a way. Another thing is a well-needed break. I would say respite care for the clinician. Maybe this is a little bit, I'll just be blunt, some of these participants can be really draining, and also being able to take a break and say, okay, for 12 weeks, another team is going to take over completely the care, and hopefully when they come back to me, I'll feel more refreshed. Weekly psychiatric appointments to manage risk and medication. So again, I see everyone once a week, which is a luxury as a psychiatrist. Both, again, I view my role as overviewing the program, but also managing risk. I don't want people who can do outpatient therapy, actually. This is not the place for them. And I also want people who can, even with their suicidal thoughts, can commit to not acting on them, and kind of having that in-between zone and keeping a very close eye on making sure we're treating the right participants. Two more things, a different clinical perspective using an integrated team. Again, kind of along the same lines of getting unstuck sometimes, when treating this population. And the last thing, which, we haven't really spoken about, but I want to emphasize, is assessing and managing eating disorders. We actually have an eating disorder specialist on our team. And one of the reasons we brought her on was actually, we noticed that people, not only most of the time had disordered eating, if not full-blown eating disorders. And again, it's not an eating disorder IOP, it's not a trauma IOP, but to at least be able to assess what is going on, and for myself as well, having that, are we doing lab work with a family doctor? Are we having a nutritionist involved? Being able to manage that in a way so that hopefully we have a sense of where we're referring people afterwards, what is going on. I'll give you a brief, we're probably out of time, I'll give you a 1-minute little story. Is we had somebody who came, the story was she had an eating disorder, it was completely, recovered, she was totally fine. And then in the first week, the secretary showed me that she had moved tons of food into the cabinets. And it was like, huh? And it was a bit of a bell for us in terms of something is not adding up here. And again, we're able to, and this is kind of along the lines of this integrative, intensive environment, be able to say, okay, well, what is going on? How is the eating disorder, playing out here, and is she fully recovered? And kind of being able to have that information and dig deeper, and also pass it along again back to the referring clinician, referring psychiatrist as well. So this is, I would say, some takeaways in terms of the program here. I imagine we're out of time for questions, but anyone is more than welcome to approach me if they have questions, both about the program, referrals. I would be happy to speak further.